So the next, we go into the next session where it is the innovations which has made impact into the minority population is the theme. And I'm going to moderate the session. Can I share my presentation to introduce my panel? Okay. Anyways, I'm finding some difficulty in sharing my presentation. What I'm going to do, I'm going to introduce my panel. We have Dr. Rajeev Vohra. He is a past president of Indian Foot and Ankle Society and a practicing senior foot and ankle surgeon, and has been an editor of Basic and Advanced Techniques in Foot and Ankle book, one of the very active member of Indian Foot and Ankle Society. The next in line is Dr. Sampat Dumbre Patil, who himself has been practicing into a rural setup and has done a lot of innovations. He has been working into a corporate setup as well as he's doing his free services to a free hospital also. He has been past president of Indian Foot and Ankle Society, a very active member of Indian Foot and Ankle Society. The third panelist would be Dr. Rahul Upadhyay, young, energetic, and dynamic foot and ankle surgeon from Jaipur, who has been a CCOT coordinator with Indian Foot and Ankle Society member, and he has been an EC member to Indian Foot and Ankle Society. And the last but not the least is Pradeep Moonot, who is a foot and ankle surgeon from Mumbai. Very innovative and aggressive, busy practitioner who also is a CCOT member. He is also one of the CCOT team member, and he has been an executive member to Indian Foot and Ankle Society. With these words of introduction, over to you, Dr. Vohra, for your presentation on to your innovations in foot and ankle.
Thank you, Dr. Rajiv Shah. Can you hear me?
Yes, go ahead, please.
So, I put my slides on. Can you hear me? See it or not?
Not really.
Yeah. Now?
Now, yes. Yes.
Okay. So we had a very interesting, previous session which was talking about the research and finances, and now we are going actually to the basics where we have to do, in a low-income group, which is an entirely different sort of problem, and the other part of the world, the developed world, may not be facing it. So I'm just going to talk about this, how these innovations can help. There are two types of innovation. One is just we are just with our technology, with our money, that we are doing certain innovations and we are advancing in science and technology. And the other type of innovation is like this. You have to innovate yourself to the resources what you have. So this is what I am going to talk. And when innovation comes, this is one plate which I'm going to talk, where it is commonly meant for lower end radius fractures, and I am sure that all of you have been using this plate. But how this plate can do wonders and save a lot of money. Now, this local made plate just costs around about $20, you can say. And what amazing work you can extract out of this plate. That is what I'm going to show. Ankle arthrodesis is a very, very common procedure which is performed for various conditions. And the options are like arthroscopic, mini, and open. And when we are not trained or we don't have the facilities for doing mini open and arthroscopic, open procedure is one which is done quite a lot in India. But when we do an open, we look towards the fancy plates, which cost, and our minority population cannot afford it. So now what we have done, we have used a simple lower end radius plate with the screws to achieve this arthrodesis. And this is not only just one case. I'm going to show you many cases where I have used this plate. If you look here in the marked varus deformity and the osteoarthritis, this plate has been used. Then in malunited fractures, this plate has been helpful me to use the arthrodesis. And you see there are a number of patients where I have used this combination, and I never had failure. I must have done around about more than 100 fusions and maybe one or two complications with this. Otherwise, I never had any problem. And then going beyond that, sometimes it doesn't give you that construct, a stable construct with one plate. You can add a similar plate like this to get a fusion in these patients. Well, every one of us are doing TTC nails because of their advantages like load sharing and large areas of the cortical contact, high bending stiffness. But we are not getting success in every nail. So how this plate can help? Let me show you. This was a patient who had a broken nail and which was done around about 1 year back, and he reported to us. And you see what we did? We just changed the nail and added this plate again to add the stability. So just by adding this, we just got that stability, and with a very simple plate, we could get the union. And now, when we find that we need additional support, primarily, we are not happy with the nail. This is the primary plate used right from the first time we are using, right in the first surgery, we are using this plate and nail combination when we have a lot of instability present when we are doing TTC fusions. Then plates. At certain places, the plates are being used for the TTC fusion. And again, these plates are very costly. And with simple implant like this, we can get fusions. Look at it. We have used just a simple lower and radius plate and just a simple DCP with a very, very economical implant. We could achieve the arthrodesis. And then another case where we added a local made humeral plate to get the stability and the fibular graft to achieve the TTC fusion. So this is another one where we have used these plate combination. You see, a very cheap local implants can give you very opportunity to treat these patients. We all know posterior malleolus is very important, and with time we are realizing the importance, and we have a superior outcomes with posterior malleolar fixation. And one thing is now the posterior to anterior fixation is preferred, whether you use a lag screw or a posterior buttress. And you see again, this plate comes to your rescue. You just use instead of using a fancy posterior malleolar plates, you just use this plate and you can just get away with the results. And I show you so many cases where I have used this plate for posterior malleolar fixation. These are all fixation, and you see there are different varieties, different sizes, and different lengths of the plates where I have used it for the posterior malleolar fixation. Okay, let's move on to pilum fractures. We all know that these have got anterolateral, medial, and the posterolateral fragments. And when it's come to the anterolateral fragment, then this plate is again helpful. You can just buttress it, fix it. So just a plate which is a very, very cheap plate, you can, and you see again a number of cases where this plate has helped us and rescued us with a very, very cheap implants to get a fixation in such cases. Another case, which is the supination and the adduction sort of injury, where you have vertical shear fracture, and we have used even here in this case. So now you see in a lot of trauma and neglected cases, this small little plate, which is a lower and radius plate, and we have innovated into the foot and ankle surgery. And now it looks that if this plate is a part of foot and ankle set and it is not a hand set, and just for $20 you can get this plate in India, and this is how. And this is a very latest paper in 2023 which shows that if you have a higher cost implants for fixation, it doesn't do much any value to the patient. So with very less expensive implants, you can give good fixations in the ankle. So I would just like to conclude that again with the same slide, that you have to do the innovations, sometimes keeping in view your situation, your environment, and the patient paying capacity, and from where he's coming. So that is what we have done, and this is one tool which we have found very useful. And thank you so much for giving me an opportunity to join this global meet, and I'm ready for any questions if there are any.
Thank you very much, Dr. Vohra. It's real innovative thing. We have also been using this kind of plates. We'll take questions at the end. Can I now request Dr. Sampat to share his screen? Over to you, Sampat.
Yes, sir. Are you able to see my screen, sir?
We are not able to see your screen. Can you try it again? While he's trying, can I ask you one question, Dr. Vohra? Dr.
Yes,
Vohra?
yeah.
So we have been using lower and radius plate in a reversed manner, where we may not be able to use the locking screw, but we are able to use the compression screw. And when you reverse the plate, it definitely gives a very good compression onto posterior to anteriorly placed plate. And then we use one or two just cortical screws. Any view onto that?
I haven't used it in the reverse fashion where I need it, but it depends what actually whether you want now. Now people are not only buttressing; they are just locking also. Particularly when you have an intercalary fragment in the posterior malleolus, there you need buttressing. But reversing I haven't used. Maybe that is I don't have the experience, but in the coming time. That looks to be a good idea that to try that, but I don't have any experience. But definitely, this plate can also be used as a compression plate. Sometimes, if you lock on the one side and use the other side, the hole which is an eccentric hole, and you can get compression with this also with this combination.
Sir, are you able to see my screen?
Yeah, we can. I think.
Rajiv sir, shall I start? Hello, Rajiv sir. Hello. 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 Hello.
We
Rajiv
can
sir.
hear you, sir. We can hear you.
So I'm going to talk about. Thank you, Rajiv sir and Selene sir, for allowing me to talk on my rehab protocol. Now, what we do differently is this is an easy rehab protocol of simulated weight bearing for prevention of chronic regional pain syndrome and deep vein thrombosis of lower limbs. So CRPS or DVT of lower limb both are issues for patients as well as treating orthopedic surgeons, and they are better to prevent rather than treat because treatment is really a issue. So see the acute stage of CRPS right foot is red, swollen, painful, hypersensitive, and this is X-ray. Even X-ray shows the changes of osteopenia, periarticular osteoporosis, and it's very difficult to treat. All of this we know. She is a 40-year lady, ankle sprain for which cast was given, and again she landed up in this particular clinical picture of CRPS. Even it is not in children, particularly chronic regional pain syndrome or reflex sympathetic dystrophy, what we talk about, is also common in children. This boy had been given cast for 4 weeks, and see this, he's absolutely unable to walk. So it's difficult to treat and even diagnose these conditions. Again, a case where ankle sprain was there, their cast was given. This young girl, in fact, she's a physiotherapist, she is unable to walk. So that condition is quite disabling. And rather than treating, we should prevent it. So what we have come up with is, during treatment, what we ask them is, if we have kept them non-weight bearing, they should keep on doing this particular thing. They should keep on pressing at the edge of the bed on the pillow in supine position, as we are not allowing them weight bearing. Still, they should do such kind of maneuver which is simulated weight bearing maneuver. This maneuver will allow even intrinsic activation of the foot, and even calf pump will be active. So it will prevent both CRPS of the foot as well as deep vein thrombosis of the lower limb. One has to push the pillow at least and hold them till the count of 5 to 10. This can be repeated several times a day. To be more objective, we keep this weighing machine vertically at the edge of the bed and ask them to put a weight for 10 kg. So it is more motivating and giving more objective feeling to the patient. If patient is in the cast, still same maneuver is shown them on the other side, and they have to do it against the plantar aspect of the slab or cast, so that they can mimic it, and the pump can be active as well as intrinsic muscles of the foot can be active. So we have to just teach the patient on opposite side. When we saw manure and monitored it on Doppler, look at this. The venous return, it increased by 4 times. See this. This is more objective evidence that we are able to see the venous return. When this manure was being done, our radiologist, she is just monitoring how much is the venous return, and venous return increases by 4 times. See this. This is the venous return. Veins get emptied very fast. See this. Only with this maneuver, the activation of pump of the calf, the veins, they empty it 4 times. The venous return is at least 4 times bigger than the normal. So we have been using this protocol in all our post-op patients or even conservative patients. Our residents, they teach this particular maneuver to all patients, and we have been using it for a good amount of time, right from ankle sprain up to trauma patients and elective surgery, all ages. We do teach them this thing, except if there is a neurodeficit or foot drop. So this, along with this maneuver, of course, this physical maneuver, we do give medical treatment in the form of prophylaxis for DVT, and this maneuver is to be continued till patient starts full weight bearing. Another point is, when they start weight bearing, it is not hypersensitive. They are used to it because it is a kind of simulated weight bearing maneuver only. So since we have employed this in our practice, we have not reported a single case of CRPS, and when this rehab protocol was given, and even DVT we have not reported. Of course, we do give the chemical prophylaxis, I mean medical treatment also along with this particular maneuver. This is a TTC fusion on one side, midfoot fusion on other side, but still see this patient, he does this particular simulated weight bearing even before we start wearing, because this was a bilateral case and we wanted him to do this. And when he actually started weight bearing, he was quite ready for it. Limitation of our study was there is no comparison group when we did not do this particular maneuver or rehab protocol. To conclude, simulated weight bearing is an easy and effective rehab protocol to prevent chronic regional pain syndrome or the reflex sympathetic dystrophy. It is helpful mechanical adjunct along with medical treatment for the prevention of deep vein thrombosis. Thank you so much.
Thank you very much, Sampat, for something which is quite elaborative and quite one which could be experimental and it could be easily taken into your practice. So the next would be Rahul. Are you ready with your presentation, please? You can share your screen, please.
Yes, sir, I'll just do that. So my screen is visible now?
And you are audible. Go ahead, please.
Right, sir. So thank you, Rajiv sir and Dr. Selene for this opportunity. And I'll be talking about innovations in foot and ankle in management of the osseous defects in the Indian population. So again, as we were talking, this particular technique of jugaad is very, very important and an integral aspect of the Indian culture. So we have been using this in providing whatever stability we can at various aspects. So sometimes we need to use this in our population also, where we sometimes have limited access to some advanced technologies, probably for the allografts. And in that case, sometimes we have to use some innovations in different ways. So we'll just look at a few cases where we have used these 3D imprinted implants to be used in various cases. So this is one first case is a 60 years old farmer who had a controlled diabetes but had a painful swelling in the right foot for 3 months, and he had been treated with multiple oral antibiotics. There was no history of tuberculosis or a foreign body, but there was an abscess, and surprisingly, it was continued to be treated with antibiotics. So it was a midfoot osteomyelitis. We took this patient for the debridement. We planned for the sequestrectomy and vancomycin coated granules to be put so that we can get rid of the infections. And once we opened this, we realized that there was a frank pulse and the destruction of the midfoot or the bones were much larger as compared to what was shown on the MRI. So once we had done that, there was a lot of midfoot gap which was removed, and the huge bone defect was there. So again, after 2 weeks, once we were able to get rid of the infection, we had to plan for the reconstruction of this big defect, as our aim was to make this patient mobile. And once we measured, the defects were measured, they were lined, and we had to figure out how to fill it up. So we used a large cortical fibular graft and some titanium cages where this graft was incorporated inside, and the cancellous graft was put around the defects. So both these cages were fit inside the foot on lateral and medial aspect, and if you could see, they were the press fit cages, which was, and we were able to get good stability in both the views, and both AP and lateral views. The stability was good In view of the previous infections, we had also put around a lot of stimulant, around antibiotic-coated stimulant to make sure there's low chances of the recurrence of that infection. And this was a 4-month post-operatively. We could see a good incorporation of the foot, and the patient was able to walk full weight bearing after the 4 months. Similarly, this was a young female, a 33 years old female who had a pain and swelling in ankle and walking difficulty. She had a deep-seated pain and a lateral ankle instability which was present. So we evaluated this patient, and we found that this patient had a large osteochondral defect. The size of this patient was quite huge. The size of this defect was quite huge, and this was beyond the scope of an OATS or the microfractures. Also, at the same time, the patient was on the higher obese side, about 140 kilograms of weight. So we planned to do a 3D printed design and replacement of that involved osteochondral defect. So this is how it was done. We did a medial malleolar osteotomy. A 3D printed jig was used, and this is how the osteochondral defect was filled up with this device called as Apisurf, the Apisealer. And the patient, this patient, if you see, yeah, this is previously how he was walking, and this is after the surgery how he was walking. Similarly, a 54-year-old male, he had a complaint of left heel pain with discharging sinus nearly 1 year back, and this was a picture. And that time he had a high HbA1c, CRP was raised, and ESR was raised, chronic osteomyelitis was diagnosed. So what we did was we did a thorough debridement, removed all the infected and dead bone, avascular bone, filled it up with an antibiotic-coated stimulant granules, and closely monitored the wound for 3 months and the infection control. Once the infection was completely controlled, cured after 3 months, we planned for a 3D printed tailored calcaneus to match the patient's anatomy, and it was downsized by about 30%. There was a porous lattice structure to incorporate with the subtalar joint. So we put it back, used as a subtalar fusion and a mobile CC joint. So this is how it was, and the patient was able to bear weight. This is 6 months post-op, though he still needs some support to walk, but he's pain-free now. So there is enough literature also, but there are not too many replacements. And the 3D custom implants for bone tumor and for chronic osteomyelitis have been commonly used at various parts of the world. Graft was not chosen because one, we had a very limited exposure to the allograft, and also autograft we could not get that much amount of autograft from the same patients. So there were a lot of advantages, and we felt that 3D printed titanium prosthesis, it could give us accurate reproduction of the prosthesis which we wanted in this patient, and anatomically matched prosthesis also gave us stability around the subtalar joint. So this is a coalition arthritis where we had used a titanium cage to correct the heel valgus. So this is how it was used on the lateral aspect, and we were able to get the heel valgus aligned, and a neutral hindfoot was achieved in this patient. So it was a good heel valgus correction. Similarly, we had used an talonavicular fusion, the same implant, and a good overall correction of the alignment. Similarly, one more 26-year-old female had a idiopathic osteonecrosis of the navicular. So it was again treated with antibiotics, but we had to take it out because the bone was completely gone. It was filled with a 3D imprinted cage in the shape of a navicular and filled up with a graft. And she had a good post-operative functional outcome with a good incorporation and a fusion of the talonavicular joint. One more patient with the osteomyelitis of the first metatarsal, and again it was completely destroyed. Once we took it out, we got the infection control. We replaced it with a strut tubular grafting and a titanium cage, and we found a good absorption, good incorporation of this cage along with the fibula inside, and patient was able to have a good post-op outcome and good functional outcome. So this is one more case where you use the same cage to get the realignment done for the calcaneus height and impingement for the both tibiotalar and the calcaneofibular impingement. So same, we did a dissection arthrodesis, opened it up, placed the cage after measuring, and did a fusion through the cage itself, and we were able to realign the hindfoot back to neutral. So the advantage of the titanium cage in the foot is it gives a very good strength, stability, negligible donor side morbidities. Need of bone graft is much lesser than the without the cage, and there is less need of additional implants to span the bone defects. Yes, there are limitations, some additional cost, possible hardware failure and reactions may be there, difficult implant removal. But since we have a very few cases, it is difficult to say that conclusively that these are the best options. But yes, the study is on the way. Thank you.
Thank you, Rahul. It was a great exposition of how you feel defects into cases and how innovatively you have worked with the cages. I'm sure there may be many questions which we'll take later on. Over to you, Dr. Pradeep, for your innovations in your journey of foot and ankle orthopedics.
Thank you so much. Can you see my slides?
Yes.
Okay, excellent. Thank you so much, Dr. Rajiv Shah and Dr. Selene, for inviting me for this wonderful program. And I know the topic is innovations in foot and ankle surgeries, but I would like to call it Jugaad in foot and ankle surgery. And that is what we have been listening to our previous three speakers, how this has helped us in getting things done in India. There's a big wide disparity in healthcare access between the metro cities versus the rural India and India versus the Western population. We had a fantastic session earlier this morning and late last night from US with Vinod Panjabi, where we spoke about limited availability or advanced systems, patient-specific instrumentation. And also we saw from our previous speakers, there is a high prevalence of neglected trauma, chronic diseases, diabetic foot workload and Charcot cases are humongous in India. Now the problem, what is the Indian reality of foot and ankle? Because of the limitations of companies.
Excuse me, Dr. Pradeep, could you take it on your presentation to screen share?
I am on screen share. You can't see it?
No, but yeah, you could take it to the slideshow, please.
I am in the slideshow. Sorry.
No.
Okay. Can you do now?
Not really. If technical team can help.
Because I can see slideshow in my side. That's why.
No, full screen. Dr. Pradeep, full screen.
I did a full screen.
Try it again, please.
Okay, I'll just stop sharing again.
Yeah, please.
And start again. Let's see. Okay, hold on. Share. Can you see my screen?
We are able to see the screen, but you have to enlarge it.
Yeah, so F5 or now, can you see it?
Try it again. Yeah. Go to the slideshow. Go to the slideshow, please.
I am on slideshow. That's why. Okay, hold on, Vapas. I'll do that.
Anyway.
Slideshow from beginning. Okay. Now?
Not really. Anyway, we can go ahead with this.
Okay. Okay, sorry. I can see the slide screenshot full screen. I don't know why you cannot do that. Is it okay, or shall you? What do you want to do?
Pradeep sir, are you on Chrome?
Yes, I'm on Chrome. So Chrome and PowerPoint on a Windows PC. Okay, there. Home. Now, can you see that? No, it's still on the.
No, not really. Anyway, you could go ahead in the same manner.
Okay.
Only thing, your animations won't be seen.
Okay, that's fine. So high prevalence of neglected trauma is there. Chronic deformities and diabetic foot and Charcot cases are quite high. Indian reality in foot and ankle, because of the limitations of companies available in India, we have limitations of implants, instrumentations options are limited. So we have Indian problems, we need to come up with the Indian solutions. The impact on Indian patients is also, we know the fact we have uninsured or underinsured patients a lot. There's a lot of out-of-pocket expenses. That's why elective surgeries get affected. Implants can be very cheap or can be expensive, and that's why we have the Indian jugaad which we need to do. So why does jugaad matters? Because innovations is rooted in clinical logic. We have to make sure that what we are presenting or giving options to a larger population. Also, we need to train our fellows and residents as well, and they practice in, again, tier 1, tier 2 cities, and we need to come up with indigenous solutions. And of course, the whole saying is Atmanirbhar Bharat, now in foot and ankle. So our innovations. So when I came back from UK, and we used to do a lot of hallux valgus, and when we came back, we did a scarf osteotomy. And what was the fixation option? Of course, for the metatarsal, we had headless screws from Arthrex and Synthes. But K-wires was not a good option, because then your wires sticking out, patient not very happy. Staples were not available that time. And of course, you could put a screw for a naked, but it takes an extra time. It is available or may not be available, and it is expensive as well. So what we did K-wires, asked a company to bend it and provide with a 1.5 mm K-wires, and they were very cheap, reasonable, less than ₹1,000. So that's less than $10. And here we go. They've been doing this for the last 10 years with excellent results.
Pradeep, are you moving your slides?
Sorry?
Are you moving your slides?
Yes.
Okay, I don't know whether everybody is able to see his slides moving, or we are stuck onto one slide only.
So we are seeing only one slide.
We are stuck on the slides. Now it is moving.
Now
Yeah.
it is, yeah.
Okay.
So titanium staples, can you see this? X-ray?
Yes, we are able.
Okay.
No, we are able to see the slide. Evolution of staples is the
Okay.
slide.
Fantastic. Okay. So initially started with the stainless steel staples with an evolution.
I think
Everything is gone off, sir.
I think, yeah, he has probably poor connection. Meanwhile, can we take questions? Yeah. So, Dr. Vohra,
Yes, sir.
there's a question for you, that any incidents of this plate going into bending or breaking?
No, we had one or two non-unions out of 100. I would say I would have done around 100 cases of arthrodesis, and in ankle arthrodesis, before this plate could fail, we realized it and we revised it. But
Okay.
fortunately, because if you see, I have been using these plates in combination with other modalities
Okay.
most of the time.
Yeah. So, Dr. Pradeep is back with us. Can you take over, Dr. Pradeep, please?
Yeah, I will. Just a moment again. I don't know why every time I have to open my PPT to share. I don't know why there is a glitch or something. I don't know. Just give me a minute and I'll share it again. And let me know where we were up to, and then I can.
So you were at the level of staples. We saw your last slide with a photograph of staple. We
Okay.
did not see the helix valgus, K-wires, or all this thing.
Okay.
We just saw your slide onto staple.
Sure.
While he's doing,
Okay. Why can I log into through my other computer,
Yeah.
and I will
Yeah,
probably
until that time, yeah, we will.
take questions.
Yeah, we will take the questions. Yeah.
Yeah.
So, question to you, Sampat.
Yes, sir.
Yeah. So there was thinking and a problem when we, had our cases where we had a weight bearing and the non-weight bearing procedures combined together. Do you think that this could help? So suppose I am doing a minimally invasive percutaneous DMMO together with some osteotomy of calcaneus or something else, and then I want to mobilize my patient. Would you recommend this kind of uh, technique? Because
Absolutely.
I want to make sure that my DMMO shifts because that's a next day weight bearing procedure.
In fact, sir, I have done it in all of my patients, and that intrinsic activation realigns. So that is a more functional rehab. So on the contrary, it is going to realign the way it is supposed to. So I have done it in my all osteotomies over the years, and I have not seen anything. I am losing my reduction or that is unstable. So whatever is unstable, that has to be checked on table, but I have not repented why I have started this protocol, and always that is helpful for me.
This is typically like you want your osteotomist to displace. Can this, the next day or day or two or three after the surgery, by this maneuver, can this displace the osteotomy?
On the contrary, it realigns, sir. I never fix my DNO modes, so I
And
keep my
nobody,
collateral intact and we don't fix it. So on the contrary, they realign according to the mechanics of the muscles. They realign it. So wherever you want in that direction, they realign. On the contrary, that intrinsic activation helps us to physiologically realign it. So it is beneficial.
great. Question to Rahul. Rahul, you know, Pradeep, if you can mute.
I'm sorry.
So Dr. Vohra, Dr. Sampat, if you can mute yourself, please. Yeah, Rahul.
Yes, sir.
See, these cages, with the fibula inside, if you put in on one side, sometimes you are not able to match it on the other side. And your fibula may be short than the cage. You want fibula and cage exactly to the same length and exactly matching to the two articulating surfaces. So can you let us know your chronology, how you really do it?
Yes, sir. So how we do it, sir? All our cages, they are marked. First, we mark the distance or the bone defect that we want our defects to be filled by. We take the exact same length of fibula as the basic, and we keep some amount of additional length of fibula along with it. So when we cut that fibula, so for example, in the first case, we use it for the two sides, for medial and for the lateral side. So we used nearly 1 centimeter extra length of fibula as a graft that we harvested. Once we have a press fit fibula inside both, because we also have to peel it sometimes if it doesn't enter inside the cage. So what happens is fibula is also not a uniform bone. It is thick somewhere and the shape changes somewhere. So we use the rasp to make it even. Once it enters inside the cage, we use a saw to cut on the edge. And the additional bone that we have used, we use the reamer that we typically use for the THR, the acetabulum preparation. That reamer we use in a ball, we keep this and we run around with that reamer and we get a nice morselized fibula, which is the extra fibula which is left with us. And we put it on both the edges of this cage.
So the same technique which Professor Meyerson reported. Oh, great. Now, when you used a 3D printed calcaneus in an infected case, what was your waiting time period?
From the day of debridement to the implantation of the calcaneus, it was nearly 3.5 months.
3.5 months. And then last question, all this cages and other thing, if this gets infected, what is your go-to?
If even the cage gets infected, probably shortening and fusion in that, but whatever position that we will get, because unfortunately all these patients that we have used, these are very cheap cages. These are not the expensive one. So maybe if we can get hold to some allograft later on, we'll try that. But as of now, as I said, that we have not done many cases to come with a conclusion of all the possible complications and all. But that might be the only thing that comes to my mind right now.
And
Rajeev sir,
Upadhyay, are you done? Are you ready
Yeah,
with your?
yeah. Now
Yeah,
can you see me?
yeah. We can see your screen, please. If you
Okay.
can take it to slides here.
Play. Yeah. Can you do that? See that now? Full
Mm,
screen?
not really.
No, we cannot.
You cannot see my screen at all, or what is it?
Now we are able to see your screen, but not the enlarged mode of it.
So I don't
Anyway,
know what this is a Mac which I'm using. Initially, I was using a PC. Both had the same issue.
okay. But you can start from the place where you ended
Yeah,
because
staples. So this is the steel staples which we started using it.
we are not seeing it. We are not seeing that slide.
Okay. Which slide are you seeing now?
It's the first slide, innovation in foot and ankle surgery is what we are seeing.
Okay, I'm moving it. Still, it is not seeing, and I'm using a keynote. So I don't know.
Uh, Pradeep sir, you had to click on the each specific slide you want to show on the left side.
Yeah. So okay, now can you see?
Yes.
Yes.
Go
Okay,
ahead, please.
I'm just going
Go
to
down.
do through the PPT only, no, or normal.
Yeah.
Okay.
Go down, please.
Yeah, that's fine. So my innovations,
Yeah.
Halex
Yeah. You
valgus.
start from here. Yeah, please.
Okay. So my innovation, Halex valgus. Initially, scarf we used to do it, and headless was not a problem. It was available, but the problems was availability of issues of staples. Again, it is easy, but it was not available, and also was expensive. So we developed a 1.5 mm. Asked one of the companies to keep it bent with different variations, and it was very cheap, less than 1,000. That's it, less than $10. Made life very easy. We have done more than 100 cases in last 8 to 10 years. Not a problem at all. Evolution from that, we designed titanium staples. Again, small staples, easy to use, and can be used in various options. So here you have a midfoot plantar closing wedge osteotomy or open wedge osteotomy, 1990 construct. Great variability, versatility, and quick stuff. Minimally invasive, various applications. Cost is low. You don't need to pay thousands and thousands of rupees. I've been using, as I said, for many years. Not a problem at all. Next is innovations. So this is a short obese woman presenting with symptomatic PCFD. And here you can see when we get an MRI done, it's just not the spring ligament. She had a deltoid sprain as well, and tenderness present on the deltoid. Now, what do you do? Sorry about animation is not there, but you would do a deltoid ligament reconstruction, a spring ligament, and of course bony. And you would need, if you were using a traditional thing, spring ligament kit, then you would need more swivel locks and fiber tapes. And this is exactly what was told when I presented this case in Baltimore last year with Lou and other colleagues. And they said, yes, we need 2 kits. I said, no, you do not need 2 kits, because what we could do is do something with single kit. So here we have a single kit where you can use it in various options. We have described it as a quadrangular construct where both the spring ligament as well as the deltoid ligaments, different limbs are taken care of. Okay, and this is the best part is you can use it with a single spring ligament reconstruction kit if you're using Arthrex. Now, if you are still more cheaper options, you can use it of 2 standalone swivel locks, 1 fiber tape, and you're still good to go. So again, Indian Jugaad has worked very well in this case. We have published this already as a case report and then a case series in Curis with excellent outcomes with hardly any complication rates. So as I said, benefits of quadrangular anatomical, biomechanical restoration, safe reproducible techniques, supports the native ligaments, and it's cheap. And third innovation, last but not the least, we've heard about from previous speakers, Shako. Everybody sees this, and here you can see this lady with a Shako, very flexible, very loose, unstable ankle, and there the talus can be seen under the fibula. Now, what do you do? Yes, if you were to do on the western side, you have options of cages. You have customized 3D printing cages. You can have a full femoral allograft. The problem with us is we do not have this case. I'm talking of 2015-16. We did not have that technology at that time, and also getting a large femoral head from bone bank, it's very difficult except you're in Tata or somewhere else. So what do we do? Indian jugaad. And also you cannot have a tibio-calcaneum option fusion because hindfoot height is important. We published this also, why a hindfoot height recreates normal biomechanics. So you should have something for the talus. So what did we do? Removed the talus, denuded it, cleaned it up, and did non-multiple pieces, strut grafts it into the space, and around that we put an iliac crest bone graft, did a hindfoot fusion nail, and this is what it is. Let's see if that works. Yes, 10 years time, 10 months, she's walking with good support, where she had come initially in a walker, in a wheelchair. So that's what the good outcome is. Okay, we have done many cases like this where we have used different ways of reconstructing the hindfoot height or the loss of talus and internal fixation versus external fixation. We have published this already in the foot with 5 cases where hindfoot height has been used, no cases of non-union, 1 superficial infection resolved. Interesting at the same thing, Dr. Rajiv Shah has described this as a bamboo hut technique and published extensively, and has made this as a very innovative technique. So just a quick case, again, so you see the significant loss, big cavity loss. You take the fibula, put it around the nail, and there you go, you get fusion. So in conclusion, innovation under pressure, which we all are for various reasons, is known as jugaad. It is cost effective. Access is there in resource limited settings. Clinical creativity and adaptability is the key. And treating and teaching your fellow colleagues, residents, and other people makes us self-reliant. Thank you very much.
Thank you, Pradeep bhai. Ultimately, you could do it. We have another 9 minutes. There was a question for Rahul. What is the cost of this 3D printed implant, calcaneus implant?
So the 3D printed calcaneus with all the sizes costs us around 300,000 Indian rupees. So if I somehow convert that, maybe about $280 or something. $2,800, sorry.
Okay.
Yeah.
Okay. So I'll quickly run one of my case onto 3D printing. I guess you are able to see my screen.
Yes, sir.
Yes.
Obviously, all of us mentioned that necessity is the mother of innovation, and we Indians love innovations, and I too love innovation. So here is something onto my innovation. A quick case: a 21 years old male had a road traffic accident, had a compound injury and vascular repair. He almost lost his medial man, and this is how he was treated with an
Sir, we
external.
cannot see the movement.
Slideshow, sir. We cannot sleep. You have to go to slideshow. You're not seeing the full.
I have gone to slideshow.
So I think there is a hitch. Now we can see. So I think you will have to do the same thing which I did. You have to just run it as a normal PPT.
What about this? Are you able to see this?
No, again, small thing. I think it is smaller.
Okay, I think it is the presenter's mode which is probably troubling.
So maybe you
What
can
is
do it because we have very little time.
Sir, just run as how I ran through it, sir. I think that is the
Okay.
best. I think there is a glitch in the thing. Yeah.
So, are you able to see this?
Yes. Medial malleolus K-wire.
Okay, so this is how he presented to us, and then we got his CT scan. This is how the CT scan picture looked, and this was the clinical picture. Okay, and then if you see his talar tilt, or if you see the stress view, the medial side was opening. And then again, the question was whether, let me try once more to show you the side slope. Is it seen now?
No, sir.
What about this? Is it seen?
So it is stuck at the APN lateral of your foot and your X-ray.
Okay.
So I think the way we did it for mine, that's the way to do it. I think there is some touch.
I will have to do
Not
this.
working. It's the same, sir.
Now it is seen?
No, sir.
No.
Hmm?
No,
No.
sir. No. So please carry on, I think, with this. We have a few minutes left with us. The same
I
thing.
will. I will try.
कनेक्शन नहीं है प्लेटफॉर्म जितनी प्रॉब्लम है
Not showing any with anybody.
Okay. I will try again.
So I think there is a glitch in somewhere because even my PC, my Mac, yours also, it doesn't run in the slide mode. You can only see it.
Yeah. So I'm again trying to open it, and maybe I'll run through the slideshow only.
Sir, I would suggest that you first make it into a full screen and then start sharing. I think that way it should run.
No, it doesn't capture only to sharing business.
So
It just
in
capture the
the
same.
sharing, there are three options. One is the entire screen option. So if you take that entire screen option after you've made it full screen before sharing, I guess that should work.
Anyway, I'm sharing it. Are you able to see?
Yes, sir. With the medial malleolus gone with KYs. That's the slide. Which we are-
Okay. Okay.
Now the CT scan.
Okay.
Yeah.
Anyway, I'll go to the slide because we are running short of the time.
Correct.
So the question was that whether this ankle undergoes ankle fusion, lifelong brace, ankle replacement, or something else. And so we decided that we are going to salvage this ankle with a 3D printing. So planned triple incision tendoankle is released, synovectomy and medial gutter clearance through ankyloscopy, removal of the implant, medial malleolus prosthetic replacement, deltodeconstruction with hamstring, plus FDL transfer. And this is how there are some other slides which are just gone by, but this is how we planned a plate through which a medial malleolus was created, and through this a tunnel for passage of hamstring graft was also created. And this is how the implant looked like. We opened it up and then we put in this plate. There are some pictures which has gone because the any vessels are not seen, but the graft with one limb in talus and one limb in sustentaculum. And this is how diagrammatically it looked. And this was the post-op X-ray with 3D printed medial malleolus and a plate to really support it. And this is how there are videos of that guy walking. He has gone back to his sports. So that is what was one innovation I wanted to share. I think we are just out of a minute. Anybody has any comment or question, we can take it, or else we switch on to the next session.
Sir, I really like the technique shown by Dr. Sampat, where it is really I'm going to incorporate, but I don't know whether it will help in MIS or not in displacing those osteotomies when you are combining a procedure which is a weight bearing and a non-weight bearing procedure.
Yeah.
Manoj,
Pradeep, you had a question.
Yes, sir. So the 3D printing, you printed the plate and the medial malleolus along with it, like a metal 3D metal medial malleolus. Is that correct, sir?
Yes.
Did you take the other side for matching it up and then got it printed? Correct, sir?
Exactly.
Very good. Very good. Can I ask one more to Sampat?
Please.
Just the last thing, Sampat. So I think it's fantastic, but most of our patients who are immobilized are in the plaster cast. So this will not probably work. So it's only in cases where they are not in a cast, but they are mobile but non-weight bearing. Correct?
It works. I showed you the photograph also that he has to mimic in the plaster cast because that intrinsic activation itself causes it. So against the plantar aspect of the cast, he has to move from within. Even that act causes the muscles to act.
Okay, excellent. Thank you.
Thank you very much. Thank you, panelists, for sticking to your time. And